Hello. So we will talk about arterial blood gas analysis. We will talk about the indications. Why do we do arterial blood gas testing? Then how do we interpret the result? And what are the special precautions that we have to take during sampling so that the misinterpretation does not happen? We also need to know about in this section that what is the stepwise approach of interpreting a result of arterial blood gas analysis. Everything we will discuss. So let us start our discussion with what exactly is arterial blood gas sample or what is arterial blood gas test. Arterial blood gas test is a test by which we measure the oxygen tension of the blood, the carbon dioxide tension of the blood, the acidity of the blood, and HCO₃. So these are the four things that we have to measure by it. So what is arterial blood gas? It is a test which measures the oxygen tension, the carbon dioxide tension, the pH, that is the acidity, and HCO₃. And by measuring these parameters, we can interpret, make diagnosis of a lot of different clinical disorders. So let us talk about indication. Why do we do it? The primary indication is to identify and monitor acid-based disorders. So identification and monitoring of acid-based disorders. Then we do ABGs for determining the oxygenation and ventilation status of a patient by determining the PaO₂ and PaCO₂. So measurement of PaO₂ and PaCO₂ tell us about the oxygenation and ventilation of the patient. So it will tell us about the oxygenation status and the ventilation status of the patient. Then there are a lot of different conditions in which the therapeutic interventions which we are doing are monitored by the arterial blood gas analysis, like in diabetic ketoacidosis. When we are managing the patient, the therapeutic interventions that we are doing, we monitor it through ABG, serial ABG. So assessment of response to a therapeutic intervention as in diabetic ketoacidosis. Then through ABG, we also identify and we estimate the abnormal hemoglobins present in the blood. Now, your pulse oximetry is one of the way of measuring the oxygen saturation of arterial blood, but it does not identify the abnormal hemoglobin. So, in case of any suspected abnormal hemoglobin, as in let's say carbon monoxide poisoning patient or methemoglobinemia patient, we need to do the ABG for detection and quantification of the abnormal hemoglobins. The number of time it is difficult to get the venous sample of the patient, but we can draw out the arterial sample. So we can also use it for sampling. So these are the various indications for getting a ABG analysis done, or ABG for taking out a ABG sample. Okay. Now, how do we do the arterial sampling? Arterial sampling can be done directly by percutaneous puncture of any artery, right? Or we can take out a sample if there is an indwelling arterial catheter present in the patient. So we have to take the arterial blood. For arterial sampling, we need to take the arterial blood, right? And this arterial blood can be drawn either from direct percutaneous puncture. So we can do a percutaneous puncture, or we can put a indwelling catheter. If there is an indwelling catheter, we can take out the sample from indwelling catheter. Now, to do a percutaneous puncture, we don't need a consent from the patient. We just have to inform the patient, and if the patient is conscious, of course, take the consent also if the patient is conscious. But for putting a indwelling catheter, arterial catheter, definitely we need to have a written informed consent of the patient. So, consent should be taken before putting a arterial catheter, right? Then normally we don't do it with the help of ultrasound. Routinely we do it blindly, feeling the artery, but number of time ultrasound can be very helpful if we are having multiple failed attempts, or if my patient is very obese, or patient pulse is very weak, very difficult to palpate, or patient is on multiple inotropes. So routinely we don't use ultrasound, but ultrasound may be useful in number one, unsuccessful attempts, unsuccessful attempts. So we need to take the ultrasound, help of ultrasound if we have it, if we are getting multiple unsuccessful attempts. Then in obese patient, then in patient with weak pulse, or if a patient is on multiple inotrope, patient on multiple inotropes, right? So in these conditions, if we take the help of ultrasound, the work would be easy for us. So what is the site selection? Which artery we should choose? Well, we can choose any artery. We can choose radial artery, femoral artery, dorsalis pedis, brachial artery, axillary artery, any artery. We just have to feel the artery and take the sample out of it. Any palpable artery can be chosen. So any palpable artery can be selected, So most common which we generally select is either radial artery or femoral, again very easy, brachial, again easy, dorsalis pedis, if I am not getting or other sites are not available, then your axillary artery can also be used. So we can use any of these artery. What are the things required for taking the sample? We should practice full aseptic precaution to prevent any infection, and we should practice the barrier, the barrier asepsis as well. So we need non-sterile gloves. We need the antiseptic skin solution to clean the skin from which we will enter the artery. We need an ABG kit. We get an ABG kit in which we already have a heparinized syringe available. If it is not there, then we need to pre-heparinize a syringe with 22 to 25 gauge needle attached to it for drawing the sample. Then we need sterile gauge pieces, adhesive bandage which we will put after taking out the sample. Then we need a bag with ice for transporting the sample, and we need the sharp object container for needle destruction. So these are the things that we need. So if I have an ABG kit, well and good, we have a heparinized syringe available in that. But if we don't have we have to prepare a heparinized syringe. So how do I prepare the heparinized ABG syringe? So heparinized ABG syringe, we need to take a 2 ml syringe, right? We need to take a 2 ml syringe, and in this we will take 2 ml, or we will take, let's say, lithium heparin. We will take lithium heparin, right? 1000 units per ml, sorry, 1000 units per ml. We will take 2 ml. We will flush the lithium heparin throughout our syringe, and we will flush it out back, right? So with 22 to 25 gauge needle, we will flush it out. We will flush out the heparin, right? So we don't want any heparin to be remaining in our syringe. Okay, we will take 2 ml of lithium heparin, not the acidic one, because that will affect the pH, as I will discuss further also. So lithium heparin would be the best one. 1000 units per ml. We will indraw 2 ml, flush the entire syringe and flush it out by heparin, right? So how do we do the art sampling? Now we can, as I said, we can choose any of the artery. So let's say I have chosen radial artery. So first I will make a position of the hand, let's say wrist of the patient. We'll put a small, let's say towel, rolled towel below the wrist, so that the artery gets straightened and it is easy to draw the sample. Then we'll clean the area with full aseptic precaution, then wear our gloves and take the heparinized syringe in our hand, palpate the artery, and where we feel the maximum pulsation, we will insert the needle at the angle of 45° with a gentle aspiration, right? With a gentle aspiration of the syringe, with a gentle aspiration in the syringe. Once I see a blood indrawn in the hub of the needle, I know I am in the artery, I would just aspirate. 2 ml of blood is enough for getting the sampling done. So we will just aspirate 2 ml of blood, then again apply a gauze piece after removing the needle, apply little pressure and put a bandage and do the dressing of the patient. So this is how we take the sample. Immediately after taking the sample, we will put the sample we'll send the sample for transport, for the analysis. So transport has to be done in a ice bag. So sample should be put in a ice bag, right, and sent to lab as soon as possible. So sample should be placed in ice and transported ASAP, as soon as possible. Now why should be ASAP? Because more the time, what will happen? The leukocytes present in the blood sample would take away the oxygen present in the blood. So oxygen consumption would happen because of the leukocytes. And in case of patients with leukocytosis or thrombocytosis, this oxygen consumption would be even faster. And not only that, delay would lead to diffusion of the gases present in the sample out of the plastic syringe. So delay should be avoided. Analysis should be done as soon as possible. So why it should be done as soon as possible? Because it reduces oxygen consumption by leukocytes and platelets. So otherwise this will produce error and fastidious low PaO₂. Apart from that, gas diffusion will happen, through plastic syringe, right, will happen. This will again produce a fastidious decrease in PaO₂. Now air bubble present in the sample should also be removed gently. Now air bubble, depending upon the concentration of the gases in the sample and in the air, the movement of the gases will take place from the air bubble, and again we will get a fallacious result. So air bubbles should be removed. So analysis, how does the analysis is done? So once we send the sample analysis to the labs, analysis is done through automated blood gas analyzer. Number of times the automated blood gas analyzer is present right beside our OT, in our OT complex or in ICU also, right? So we can also do the analysis by putting the sample in this automated gas analyzer. So analysis is done by automated blood gas analyzer, right? Automated blood gas analyzer. So what are the things which is analyzed? There is electrochemical sensor. Now this electrochemical sensor, this would analyze the pH, the PaO₂ and PaCO₂, right? PaO₂ and PaCO₂, and pH will be analyzed, and rest other, that is SaO₂ and your HCO₃. It is calculated by the formula, right? So how are these analysis and calculation done? What are the formulas which are used? For PaCO₂, for measuring the PaCO₂, for analyzing the PaCO₂, PaCO₂ is measured using a chemical reaction that consumes carbon dioxide and produces a hydrogen ions, which is sensed as a change in pH. So this is the principle by which the PaCO₂ is analyzed or measured. PaO₂ is measured by using oxidation reduction reaction which generate a measurable electric current, and pH is measured indirectly by electrode tip, which determines the voltage using reference potential calibrated pH unit fed in the monitor. So pH, PaO₂ and PaCO₂ is analyzed, and rest two values are calculated. Bicarbonate is not measured directly, as I said, it is calculated by the Henderson-Hasselbalch equation, which we will discuss, and oxygen saturation, arterial oxygen saturation is again calculated by Severin-Gauss equation, right? So it is calculated by Severin-Gauss equation. So these two values are calculated value. Now, arterial blood gas analysis is affected by the temperature. The measurement is affected by the temperature. And most of the gas analyzer measure at 37 degrees Celsius. They report at 37 degrees Celsius, irrespective whether the patient temperature is whatever. So, modern automated blood gas analyzer report pH, PaO₂, PCO₂ at either 37 degrees Celsius or at the patient's body temperature. But most of the laboratory report the values at 37 degrees Celsius, even if the patient's body temperature is different. So this would definitely affect the value, but most of the lab report it as fixed 37 degrees Celsius. Okay. So what is the normal value? To understand, when we get the result of ABG, we see the ABG let's say result. What is the normal value? And to understand the abnormal, we have to know the normal value. So first, what is the normal value? So the normal values, little variation can be from patient to patient. So range is what we have to remember. So normal values, the normal pH is between 7.35 to 7.45. The PaCO₂, the normal value is between 35 to 45 mm of Hg. And HCO₃, the normal value is between 21 to 27 milliequivalents per liter. Now, apart from this, we have to see the PaO₂ and SaO₂ as well. So, PaO₂ and SaO₂, their normal values are not defined because threshold below which the hypoxemia, tissue hypoxemia will happen is not known. So, their normal values are not defined, right? So what is reasonable value which we expect as normal? The PaO₂ above 80 mm of Hg, and saturation above 95 is reasonably normal, right? Okay. Now, in non-smokers, it is only 1 to 2% we will get carboxyhemoglobin, but in smokers up to 15% carboxyhemoglobin may be present, right? So in non-smokers 1 to 3% carboxyhemoglobin, right? And in smokers it is 10 to 15%, right? So in smokers it could be increased to 10 to 15% of carboxyhemoglobin normally present in the sample. 1% meth hemoglobin would be normally present. So meth hemoglobin 1% would be normally present. Okay. So by seeing the sample, what are the things that we analyze? So first, we discussed about the indication of ABG. One of the indication was for determining the oxygenation and ventilation. So let's say first thing which we see the ABG result and what do we analyze is oxygenation of the patient. Now PaO₂ and SaO₂ are the two important things which will help us in determining the oxygenation of the patient, and as I said, above 80 is considered reasonable when the patient is on ventilatory support, etc. The target is we have to keep it above 60, right? Between 55 to 60. So oxygenation is what is the, let's say, one of the important thing which could be determined by the ABG sampling, ABG result. So how do we determine the oxygenation? By measuring the PaO₂ and SaO₂. So by this PaO₂ and SaO₂, we can interpret lot of things. We can get A minus A gradient, that is alveolar arterial gradient, which will help us in diagnosing lot of alveolar diseases. Then it will give us the PaO₂. By determining PaO₂, we will be able to calculate PaO₂ FiO₂ ratio, which will help us in diagnosing ARDS and determining the level of ARDS, mild, moderate, severe ARDS. Then it will also help us in calculating the oxygen delivery, right, by putting the PaO₂ in the formula to calculate oxygen delivery, right? We should always keep in mind that hyperoxemia and hypoxemia both are deleterious. So remember, we don't want PaO₂ to be very high also. So hyperoxemia and hypoxemia both are deleterious, both are bad, right? And one more thing we need to remember, that as the age increases, the normal value of PaO₂ may be a little bit decreased. So PaO₂ can vary with age, and PaO₂ 104 minus 2, 104.2 minus 0.2 into age is the age correction which we can apply. Okay, so these things we have to keep in mind. So one thing we determine is oxygenation, and the next important thing which we determine by ABG, the appropriateness of ventilation. Appropriateness of ventilation. So how can we determine the appropriateness of ventilation? Now this is by your measurement of pH, by seeing the pH, PaO₂ and base excess. So by the changes which would happen in this, the disorders of the ventilation can be divided into your acute and chronic respiratory acidosis and alkalosis. Acute and chronic respiratory acidosis and alkalosis, respiratory alkalosis, right? So when will respiratory acidosis happen? Respiratory acidosis happen due to any reason why alveolar hypoventilation is happening, right? So in respiratory acidosis, the acid base balance is disturbed because of alveolar hypoventilation. So I am talking about respiratory acidosis, right? Why this is happening? This is a, if I define it, it is a disturbance of acid base balance, acid base balance due to alveolar hypoventilation, alveolar hypoventilation, right? So how would be it characterized by? The primary problem which would happen is your PaCO₂ would increase above the normal. So normal is 45. So in this, the PaCO₂ would be more than 45 mm of Hg, and pH would decrease. The pH would be your less than your 7.35, the normal. So pH would be decreased, PaCO₂ would decrease. Mechanism, etiology, that everything is divided according to the site which is happening, which is getting affected. So because of central hypoventilation or because of alveolar membrane issues, for any issue, your alveolar hypoventilation is happening, we will get respiratory acidosis. Now respiratory alkalosis is because of alveolar hyperventilation. Now alveolar hyperventilation. So what will this alveolar hyperventilation produce? It will decrease the PaCO₂ and it will increase the pH. Well, in acute alveolar hyperventilation, acute respiratory alkalosis, the PaCO₂ is decreased and pH is increased. But in chronic, the PaCO₂ decreases but pH comes in the normal range because of the compensation. So acute, your PaCO₂ would be less than 35 mm of Hg and pH would be more than 7.35. And in chronic, it would be, the PaCO₂ would be your less than 35 but pH will become normal. Now anything, etiology could be variety of reasons like your anxiety, pain, your psychotic disorders, hyperventilation syndrome, anything leading to alveolar hypoventilation. So lungs are stimulated in this because of variety of reasons like anxiety, your pain, your panic disorders, your fever, right, psychosis, all this stimulates the lung. So stimulates the lung to remove the carbon dioxide. Now this would sometimes produce acute hypocapnia. So this can cause acute hypocapnia. Now acute hypocapnia can be deleterious because it will cause cerebral vasoconstriction, acute cerebral. So acute hypoventilation can, hyperventilation can cause acute hypocapnia, which can cause cerebral vasoconstriction, which can lead to dizziness, and which can cause syncope in the patient. And apart from that, it can cause peripheral hypocalcemia because of increase in calcium attachment to the albumin because of your alkalosis. So it can also cause hypocalcemia. It can also cause decrease in serum potassium and HCO₃ minus, right? Serum bicarbonate. Okay, so all this would be the precipitating effect of your respiratory alkalosis. Now, apart from this, by seeing the ABG, we would also analyze the metabolic acid base disorder. So, metabolic acid base disorder. So, to diagnose metabolic acid base disorder or metabolic acid base balance or disorder, we need to see three important things. We need to measure the pH, PaCO₂, and the base excess. Now, basis of changes which have happened in it, we can classify it into metabolic alkalosis, and your metabolic acidosis, right? So, metabolic alkalosis and metabolic acidosis is what we can diagnose. In metabolic alkalosis, the pH of the patient would be high, the base, the HCO₃ would be, let's say pH would be high, HCO₃ would be increased, and PaCO₂ as the compensatory will increase. Now, in acidosis, the pH will decrease, the HCO₃ will decrease, and as the compensatory, PaCO₂ has to decrease. We will talk about what is this compensatory. So, these are the things that we need to, we will interpret with the help of your ABG ABG result, the ABG analysis result which we have got. Now, what are the sources of error and what we have to avoid in order to have the correct result? So, as already I told earlier, that we should send the sample ASAP, because delay in the sampling can lead to errors, and one of the primary error is consumption of oxygen present in the blood by leukocytes. So, leukocytes can consume the oxygen from the blood, the oxygen and carbon dioxide can diffuse out through the plastic syringe, air bubble present in the syringe can lead to the changes in PaO₂ and PaCO₂ value. All this can be minimized if we get the sampling done within 15 minutes. So, if sample is left at room temperature for more time, then gas diffusion through plastic syringe and consumption of oxygen by leukocyte can falsely decrease the PaO₂, right? And we should get the sample analyzed within 15 minutes. Now, the other potential cause of error in the result would be the heparin which we have used. If we are using acidic heparin, then it can affect the pH, especially if the remnant of heparin is present in the syringe. So, I told you the way to flush the syringe to produce a heparinized syringe. We have to take 2 ml of 100, let's say of say 1,000 units per ml of lithium heparin and use it to flush the syringe. We don't have to leave any remnant of the heparin in the syringe. We have to just flush the syringe with heparin. So, heparin that is added, if acidic heparin is used, then and dismissal of heparin from the syringe is incomplete, then it can dilute PaO₂, resulting in falsely low value, and it can also affect the pH. When ABG syringe is used, right, amount of heparin solution used should be minimized, and at least 2 ml of blood should be obtained. If the ABG syringe is used, 2 ml blood should be minimum obtained. Air bubble, if it is present more than 1 to 2% of the blood volume, it can cause falsely high PaO₂ and falsely low PaCO₂, right? And this magnitude of the error depends upon the gas tension between the sample blood and the air bubble, right? So, and it also depends upon the surface area, exposed surface area. If, let's say, we can increase the surface area by just agitating it. So, if we take the sample and if we just agitate it like this is not something we have to do. We have to gently tap and remove the air bubble, not agitate the sample. That is increasing the surface area of air bubble. And the time from the specimen collection and getting analyzed, it should be not more than 15 minutes. So, These error would be minimized if gentle tapping of the syringe is done to remove the bubbles from the sample, and sample is analyzed as soon as possible. So these are the potential errors which can produce in the result of the ABG. We have to minimize it to get a better value.